log in. Please ensure that you do not use the raise hand button. Please put your questions in the Q&A block that we have at the bottom, and at the end of the session, the speaker will respond to all the questions. Please do not raise your hand because that will not be recognized and it will not be read. Please just make sure that you put your question in the Q&A panel. The CPD points will be loaded on our SADA platform in the next week. We appreciate the fact that we have not been able to upload the past CPD certificates. That is something that we are working on. It's part of the process, so we do apologize for that. We really do apologize for not uploading the certificates. We've received a lot of queries from members, but we are in the process of addressing that. So without wasting any time, I'm going to hand over to Dr. Ian Erasmus, who is the president of the Pretoria branch that is hosting us this evening to introduce us to our speaker for the evening. Over to you, Dr. Erasmus.
Hi, thank you, Dr. Erasmus here. Forgive my appearance. Both my hairstylist and my makeup artist couldn't make it tonight due to lockdown. So just a joke. We want to welcome Dr. Eva Burger to this webinar tonight. Less is more. At first, I thought he was going to speak about the lockdown and less materials available because of the lockdown, but it's apparently not that. Welcome, Dr. Burger. Dr. Burger joined Dr. Bauer in Jeffreys Bay in 2009, and together they expanded their business from a successful one-man practice to the business, flourishing business they're running today. Dr. Burger enjoys meeting new people and the large number of foreign patients he deals with in his favorite part of dentistry, and that is creating beautiful smiles, implants, and aesthetic dentistry. He's married to Carmen and have a delightful little boy called Alwyn. I know he can't play golf because he's only apparently they can only surf, and they have their board meetings at the Point Surf Spot in Jeffreys Bay. And he also enjoys biking. What is not his favorite is jogging, but he does that on the recommendation of his dietitian, apparently. He needs to. So, Dr. Eva, thank you for making time for us tonight, and have a good lecture. Thank you.
Thanks a lot, Ian. Thanks for the introduction. I'm honored that the guys from Pretoria asked me to do the lecture. The nice thing about doing a lecture for the guys from Pretoria is you're allowed to do it in Afrikaans. So fortunately for me, we're going to do the whole thing in Afrikaans tonight. Is everyone happy with that? Can we go on in Afrikaans? Can we?
No, I think we are on. You're not allowed to. You should stick to the English, unfortunately, because unfortunately we have an audience of South Africa tonight. So, but we'll invite you another time when there's a flight from there to here.
I'll send the Afrikaans slides to you guys in Pretoria if you don't pick up on all the English. Don't worry, I did prepare in the English lecture.
That's fine. You can continue.
Can I go on? Can I share my screen?
Yes.
Right. Thanks so much for having me. I was quite surprised when the guys asked me to do a lecture from Pretoria. Like the last time I was in Pretoria, the Springboks lost 52-16 to the All Blacks. So it wasn't very fond memories for me. And I was hoping to do the thing in Afrikaans, but apparently minder is meer, should be less is more. And okay, my pointer doesn't work. And so that's the topic. The topic for tonight is less and more, and there's beauty in simplicity. Just to introduce myself quickly, my name is Evert Burger. I'm a dentist in Jeffreys Bay. I'm married to my wife, Carmen. I've got a beautiful boy called Alwyn, and we've got two dogs called Baba and Charlie. My wife, Carmen's also a dentist. She studied in Pretoria. Alwyn and Charlie and Baba has never been to Pretoria, and I was there the last time the Springboks lost. So thanks so much for the Pretoria branch for having me. I just want to get my view right. We live in Jeffreys Bay. We don't play golf. We enjoy outdoor lifestyle. We tend to surf a lot. And we go out on the boat a lot, and we always put safety first and fun second, as you can see with Alvin's bright life jacket there. Then I do dentistry with my partner, Jan Bauer, in our practice, J-Bay Dental Studio. I've been in the same practice since starting dentistry 11 or 12 years ago. And we have a podcast called the More Than Dentistry Podcast. I also started the Composite Club, which is a place where we teach dentists composite dentistry, and we go out to the Crom River in the Eastern Cape. We have some wine, we have good food, and we do composite dentistry, and we learn young dentists how to do more complicated cases using composite only. And tonight's topic is the less is more approach. I read this article from Ricardo Mitrani in September 2019 talking about the less is more approach. And all I want you guys to take out of this talk tonight is only basically two things. The first one being, we need to start getting involved in social media. We're in a time, and especially now with the lockdown, we're all doing this thing online. The internet and social media is such a massive thing on our lives. We need to get involved in social media. And the second thing is being in this post-COVID state we're in at the moment, we are we've got people with a lot less money, and we need to start giving solutions in dentistry to people that really can't afford the high-end dentistry that we like to sell to patients. We're going to go through some cases that I do using the less is more approach. And then I want to tell you guys about some people that influenced me in my life in the past couple of years. And I want to quickly talk about a little bit more than dentistry outside the surgery. Then we're going to have a competition. And then after the competition, we're going to have Q&A. So the competition is very exciting. If you win the competition, you're going to come down to the Eastern Cape, to the Crom River. You're going to spend the weekend with us. We're going to teach composite techniques. You're going to eat some amazing food that my wife makes, and you're going to go on the boat with Alvin and do some skiing and tubing. And then my friend Altis will be here to have a drink with you and have a beer. So please listen to the lecture. At the end, I'm going to ask 3 questions. You need to answer those 3 questions, and you can win this weekend away to the Crom River with us. So please pay attention. So a couple of nights ago, Darby Root gave us his lecture on the economy, and I took some notes, and I read, you can see the economy is to contract by 10%. The average South African will be 15% poor, and we've got 2 million job losses and 100,000 businesses. And you can see that's quite a depressing state. So I just went on the internet, and I went on Facebook, and I went on Instagram, and I started playing around. And the cool thing about the COVID and the lockdown is we actually had these devices, and we could spend time online, and we could connect with people. So one of the things that came out of the lockdown that we all are involved with, and we all are talking about at the moment, is virtual appointments. I'm not sure how many of you guys are actually doing virtual appointments, but we've started to dabble in virtual appointments and especially in the hard lockdown, I was speaking to patients and giving them advice on their teeth and maybe giving them some hope on what we can do for them. So the virtual appointment thing was quite an exciting thing for me that came out of the whole lockdown. And one of the interesting things I found was making an appointment with the dentist these days. I just want to get my slides a little bit changed here. I'm sorry. Making an appointment with the dentist is almost like online dating these days. And I'm going to take you through the steps quickly just to show you the similarities of making an appointment and online dating. The first thing is patients and potential partners find you. Now, we don't know how they find you, but they maybe get referred by a friend or someone tells you about it. And what they do is after they found you, they just look at you and they see what you're up to. They go on your Instagram account or your Facebook or your YouTube or whatever you've got, and they start and look around. And this is called stalking. It's also called a lurker. You must remember that word, lurker. So a lurker is a guy or a girl that sits in the shadow and just looks at the work you do, look at your pictures you post. They never mention anything. They never say anything. They just observe. Then the next step of the lurker is they start engaging in the stuff you post. maybe they'll like your post, maybe they'll put that poop emoticon next to your before picture, or maybe an LOL, and then they start following you as well. So at this stage, you start realizing there's people out there that's following you and they're looking what you're doing and they start interacting with you. The fourth thing they do is they slide into your DMs. So if you've never heard the term sliding into your DM, that means they're sending you a direct message. And at this point, you're now basically friends and you're talking, and they'll send stuff like, I'd love to get my teeth whitened in that picture that you posted, or they'll write, how much you charge for a rehab and making teeth pretty, and I'm just asking for a friend, and things like that. And that's the typical messages we start getting. And then the next thing we do is they ask for your number. Now, it's very important here to know that this is where it splits the dating, online dating, and the dental appointment making. If a patient wants your number, you need to make sure you give the right number. If you want to date this person, you give your personal number. But if you only want an appointment, you give them the practice number. And I'm saying this very tongue-in-cheek and joking about it, but it's very, in my opinion, it's one of the things that all of us should be getting involved with, is getting online and start having a social presence. If you're not having a social presence, there's people out there in the lockdown, in the time they're spending at home, they're out there on the internet, on their devices, and they're looking for treatments, and they're looking for solutions for their problems. And if they're not going to find you, they're going to find someone else, or someone doing the job. So it's very important to start getting involved in stuff like social media and stuff like Facebook. Now, to get back to Davy Rood painted quite a bleak picture for us when he gave his talk. And it's easy to get depressed, but we need to start thinking outside the box and start giving solutions to our patients that might have less disposable income than they had a couple of months ago. So we need to start looking at solutions for patients where we can give them more value and charge them less for it. And that's where the less is more approach comes in. So Ricardo Mitrani is a prosthodontist from Mexico, and he writes in the Spear Digest. He writes a lot of articles and short and concise opinion articles, which I find very interesting. And he's very big into implants, and he's big into minimally invasive dentistry. So I kind of follow the work he does. And the less is more approach, he wrote in September 2019. And ever since I read the less is more approach, I kind of kept it with me whenever I did a treatment plan. And it's such a little basic thing. And it just maintain the most tooth structure, minimize the amount of teeth involved, utilize the least invasive techniques, delay treatment, and phase treatment. And every time I'm sitting with a treatment plan, I've got this less is more approach next to me. And it's kind of like it helps me to give the best treatment plan that's minimally invasive. And there's a thing you should go read up about it on a Spear Digest magazine, and something we're going to go through today. And we're going to look at cases and how I treated cases using this less is more approach. Another interesting article Mitrani wrote was Patient Communication in the Age of Information. That was September and March 2019. And one of the things that came out of there was, he said, we should see ourselves and be seen by patients not only as care providers, but as oral health educators, and be able to walk them through a buyer's journey, allowing them to understand the implications of choosing a given therapy and the repercussions of this may have in the future. So I think it's very important. We in Jeffreys Bay, we sit in a kind of a retirement town, and we see a lot of patients at the end of the journey, the end of the line. All the guys coming from Pretoria moving down here and to retire. And we see a lot of failing restorations on a lot of patients. And it's at a critical time in their life where they maybe had big treatments done 10 or 20 years previously or 30 years previously, and the things are failing at a very critical stage. A lot of these patients are old, they can't afford other treatment. And then we have to go to dentures and things like that. So it's interesting for me to follow the journey all the way through, and it's it's a big responsibility on dentists to make sure that we educate our patients, not just give them a solution, but like you said, be seen as a care provider and an educator more than just a provider of a solution. So what's the conversations I normally have with my patients? I always tell people, when we do treatment planning, we need to do minimum invasive dentistry. And the conversation I always have with them is, the one thing that's not that's not discussed, we're not going to compromise on, is we need to treat health. So anything that's pathology, we need to treat. And that's no matter how we treat it, the way we treat it is, we can discuss that, but we need to treat health. The second thing we need to look at is function. We need to restore function. So once we restore health, we need to restore function. And that's the second part. I always tell people, spend money on your health, then spend money on your function. And only thirdly, we start spending money on aesthetics. Now, I like aesthetic dentistry, but aesthetics is not the most important thing. Being minimally invasive is very important. Treating health and giving a patient function back. And I always tell people, if we do these things right, aesthetics at the end of the day, I can almost give you for free. If you restore your function, aesthetics is very easy to give a patient. So when going into the cases, all of the cases I'm going to show tonight is cases that I was, first of all, patients came for second opinion. And the reason they came to me was the first opinion that they got was too expensive and they couldn't afford the treatment. So it's not like they didn't like the dentist or didn't agree with him. They just couldn't afford the treatment. And we're going to see more and more of these people. And all the cases I'm going to show you tonight found me on social media. And that's basically all I want to tell you tonight is be available online because people are looking for you. Make sure they see your work and maybe give them a treatment plan that fits their budget. It'll be nice to give the amazing all-on-4 treatments to everyone that needs it, but people can't afford it. So we need to start giving treatment plans that's maybe thinking out of the box and treatment plans that patients can afford and actually go ahead and do the work. So the first patient I've got here is Bertus. Now Bertus is a 27-year-old. He's obviously, he works in Port Elizabeth and he's looking for a girlfriend because right after his first appointment, he contacted Terry Lynn on Instagram and sent a friend request. So he's definitely out there in the market. And his main complaint was aesthetics. He wanted to get his front teeth sorted out. The initial treatment plan that was given to him was to do 4 crowns. That's what he said. So I'm sure it wasn't 4 crowns. I'm sure it was 4 indirect bonded restorations, maybe veneers or something. And the reason Bertus didn't go for that treatment plan was just cost. So we needed to give him a second treatment plan that fits his budget. When looking at his teeth, you can see quite a lot of wear on the front uppers, but the rest of his teeth wasn't in too bad state. I don't have all the pictures here with me, but the treatment plan we looked at was doing direct bonding. And direct bonding can be one of 2 things. You can do freehand composite veneers, basically, and use the doll technique to open his bite slightly and let the other teeth over-erupt over time. The other one is we can do a wax up, and after the wax up, we could do injection molding technique that Dr. Mark Bowe spoke about last week as well. And those are the only 2 options I think that we had for him. And eventually, when looking at his budget, we decided to do direct bonded, freehand bonded veneers, composite veneers. And the treatment took us maybe an hour and a half, 2 hours to do. We opened his bite slightly. We filled in all the wear facets. And Bertus was super happy about it. He's out in the dating field trying to get his next girlfriend. And when looking at the 5 elements of the less is more approach, did we maintain the most tooth structure? Yes, we did. We didn't. We never even filed down any of his teeth. We didn't prep any of his teeth. Did we minimize the amount of teeth involved? Yes. We only worked on the teeth that was necessary. The front 6 teeth we did composite bonding on. Did we utilize the least invasive techniques? Yes, we did. Did we delay treatment? We didn't delay treatment. We did the treatment immediately. But delaying treatment also means is maybe delaying that composite the prepping the tooth for porcelain. So this might be a phase in his treatment. I'm going to go to the next point, phasing treatment. Bertus must know that in the next 20 or 30 or 40 years, obviously he's going to have problems and he might end up getting those porcelain veneers, but he might end up getting them 15 or 20 years later, and then they might last him another 15 or 20 years. So it's very important to explain to the patients that you're in this process and you're in this thing, and getting the immediate treatment is not always the best thing. Try and delay the treatment as long as possible for prepping those teeth is the ideals. And that's why I love doing composite bonding so much, because it's really phasing treatment. And if you can explain to your patients the phasing thing, once you get complications, it's really not that bad. The next patient I want to look at is Jimmy. Jimmy is 35 years old and he's recently divorced and he's getting himself ready to get back on the market. And you can see his main complaint was obviously also aesthetic problems. And he went for a quotation with another dentist and he was quoted for 6 porcelain veneers on the front teeth. Now, there's obviously nothing wrong with that treatment. I suggested, he said he needed maybe a cheaper alternative. So I suggested, let's remove the crown on the 2-1 and let's do 1 bonded porcelain ceramic on the 2-2 and maybe do some composite bonding just to fix the other teeth. And the first thing we did was we did a wax up and we showed him what it's going to look like. So in my mind, I thought Jimmy is a pilot. I think he works in Africa somewhere. I think 2 ceramics is going to be ideal for him, maybe do a tooth whitening. So we did the wax up, we placed it in his mouth and we gave him the quote and he was super happy with everything, but he still couldn't afford the ceramics. So he said he needed a even cheaper alternative. So we had the wax up done and then we made injection molding with heated composite, and we placed composite veneers using injection molding. And that's obviously also a very cost-effective treatment. And there you can see the afters. The soft tissue in this case hasn't healed yet. As I said, he's a pilot working in Africa somewhere, so we had to take pictures immediately. But that's a very nice alternative and a good aesthetic result, in my opinion. And we checked all the boxes of the less is more approach. We maintained most of his tooth structure. We minimized the amount of teeth involved. We utilized the least invasive techniques. We delayed treatment and we phased treatment. And the same as for Bertus is this patient will end up with more treatment. They'll probably end up with more ceramics, but we're just buying time and we're going through the buyer's journey with him, and we're trying to get him when he's retired at 80 or 90 with still all his teeth in his mouth. And the most valuable thing we've got in dentistry is enamel. So we want to not cut that enamel if possible. So the next patient is 41-year-old Riet. She went to an opinion at a prosthodontist 10 years earlier, and she got quoted for a full mouth rehab using bonded porcelain. And back then, Riet's a stay-at-home mom, and her husband couldn't afford the treatment. And like I say, all these cases are cases that come to me because of affordability. And I'm not sure about everyone else, but in the Eastern Cape, affordability is really a big treatment, a big issue when treatment planning. So Riet delayed treatment for 10 years. And 10 years later, she had a lot of sensitivity. You can see all the wear on the lower teeth, on the lower 6s. And we needed to do some treatment. So the treatment options we had for her was obviously doing a full mouth porcelain rehab for her. And I didn't want to go that. I thought she's way too young for that. So the options I gave her was to first phase the treatment. And the first phase of treatment was to do temporary build-up. So I built a lower teeth up with composite, direct bonding composite. And I bonded the upper teeth in composite. And we just left that for 2 or 3 months for her to get used to the new part. We opened the vertical dimension. We left her to get used to it. 3 months later, we got her down to Jeffries. She flew down from Joburg. And what we did was on the lower 6s and 5s, we did Emax overlays. And in the front teeth, we just did composite veneers, freehand composite veneers, polished it up and let it go. Now, obviously, aesthetically, it's not the greatest case. I think we could have done something on the 4s and the 5s, maybe to close those buccal corridors a little bit. And aesthetically, I don't think it's the best case. But what we did was we minimized the amount of teeth involved. We can always go back and place something on those 4s and 5s. And I explained to her beforehand that it's probably going to be better if we do, but it's just another thing that might go wrong. So let's leave this for the next 5 years. We obviously once again maintain tooth structure. We minimize the amount of teeth involved, and we utilize the least invasive techniques. Delayed treatment. We delayed treatment. Well, she delayed treatment for us for 10 years. So 10 years later, she still got the bulk of her enamel in the mouth. And and we phase treatment by doing a temporary phase first. And in the next case, I'm going to explain to you how I changed my mind on the phasing treatment a little bit. And I might be wrong in this, but this patient is Cornell. He's 46 years old. The interesting thing for me is men always come and say, listen, I don't think there's anything wrong with my teeth, but my wife sent me to you. So just a little tip of advice: if you're going to do any marketing in your practice, market to the wives, not the husbands. If you want older farmers, market to the older farmers' wives, because the older farmer doesn't give a damn about his teeth, but his wife will, and she will find you online and she will refer the patient. So Cornell is 46 years old. You can see he's got quite a bit of wear on the upper teeth. He's got a non-vital 2-1. On the lower, he's got a substantial wear on the lower 6s and 7s. And previously, he had some composite buildups done on those teeth that didn't last very long. So he also went for another opinion where he was quoted for getting crowns on the lowers and anterior veneers on the uppers, porcelain veneers. So what I suggested to him was, actually, I'm going to show that slide. We kind of split his mouth in two, and on the lower left-hand side, we placed composite veneers, but we used injection molding technique. So what we did was we got the lab to do a wax up for us, and we just, in that slide, you can see we did injection molding with heated composite, and we placed the composite veneers on the left-hand side. On the right-hand side, I used Tetric CAD, and the Tetric CAD Serec block, and I mold 3 overlays for him, 3 Tetric overlays. So this is the temporary phase, but the way I explain to this patient is I like doing a temporary phase in composite, because composite is such a nice manageable material. You can add to it, you can take away from it, you can polish it very nicely. If it chips, you can fix the chair side. So I like to do the temporary phase in composite just to get the bite right, get the patient used to it, before I go into a harder material like a ceramic or a zirconia or anything like that. It's also very nice for the patient, and the patient gets used to it much quicker. It's much softer on their teeth. So in the past, I used to do the temporary phase 2 or 3 months later, like I explained with Riet. I would take it off, and then I would go and place permanent ceramic overlays. But in this case, I said to the patient, and that's the kind of way I'm moving, is phasing the treatment, but making the temporary phase much longer. And especially in a younger patient like this, he's 46 years old. So I said to him, what we'll do is we'll place the composite overlays, and we'll leave that as long as possible. We'll see how it goes. We'll see how it matures, and we can fix anything that goes wrong. So delaying the treatment, not just for a couple of months, but over the long term. And then on the anterior teeth, I did direct freehand composite veneers. And the reason I like doing freehand composite veneers and not doing wax ups and using an injection molding technique is I might be wrong, I always struggle to find that I'm getting a proper marginal adaptation. And when bonding and when doing these things, the bonding is the most important thing. So when I do these direct veneers, I want to get my matrix band in there. I want to use my loops, and I want to see that I'm getting proper bonding. I want to see that I can etch properly. I want to see there's no marginal leakage, no fluid creeping in. And when doing these injection molding cases, I'm not sure about that marginal bonding. So I always like to go for the direct freehand composite veneers. The nice thing about doing that is also saving the patient a little bit of money. And there you can see the before and afters. You can see it's not an amazing case. It's not something that you want to maybe show to everyone, but that's a case that fitted his budget. We were super minimal invasive. We maintained the most tooth structure. We minimized the amount of teeth involved. We utilized the least invasive techniques, and we're delaying treatment and we're phasing treatment. And like I explained to this patient, we are now married, and I'm going to see him for the next 5 or 10 years, and we're going to see what's happening, and we're going to see what's breaking and what we can fix. And when we get to a point where we realize it's not fixable with composite, then we'll go over to the next phase of our treatment, and we might start using porcelain and might start being a little bit more aggressive. But the next patient is Julie, and she's 75 years old, and she was an amazing woman to treat. She actually came all the way from Durban. Once again, she went for a quote, got a full mouth porcelain rehab quote, and she found me on Instagram or Facebook, and she flew down with her husband. And the cool thing is they were married for 50 years at this point, and her husband gave her a present, a 50-year anniversary present, is getting a tooth fixed. And if a picture can tell 1,000 words, that's what it looks like to be married for 50 years. And I thought to myself, if the lady looks like that after 50 years, what must the husband's teeth look like? So I got him in the chair quickly and we took a photo. And there you can see what the husband's tooth looks like being married for 50 years. It's actually true. You can count the rings. There's 50 rings in that case. Anyway, getting back to Julie, same approach we did for everyone. We used composite overlays and inlays in the posterior, and composite veneers in the upper anteriors and lower anteriors. All did freehand. We did everything freehand, and we managed to get a decent result. Not, once again, it's not the best result ever, but looking at the budget she had, looking at how much money she could spend, we got a fairly good result, and we managed to treat the patient completely. We didn't have to do any sections. There you can see the other after picture. And once again, we maintained tooth structure. We minimized the amount of teeth involved. We utilized the least invasive techniques. We delayed treatment and we phased treatment. And this patient went back to Durban. She's super happy. And when doing these cases, I lost a lot of sleep with complications and failures and thinking, one of these days, the patients are going to come walking in with all these failures and all these complications and all these things breaking. And then I read this interesting article by Robert Berkeley. He said, or an interesting quote, he said, the best dentist makes the patient worst at the slowest rate possible. And like I said earlier on, our patients are older patients and we're seeing them at the end of the life. So what you want to do is protect the natural teeth for as long as possible and get them to 80 and 90 and 100 with all the teeth still in the mouth. So if I've got a failure on a composite, it's not really the end of the world for me because I can fix that. I'd rather let my composite fail than let the underlying tooth structure fail, or having a big fancy crown, but underneath nothing works. So complications and failures will always be there. We'll always have problems. We'll always have things fail. Our implants fail on a daily basis. Our bridges fail. But if a composite fails, it's not the end of the world. We can fix it chairside and we can fix it very cheaply. So complications we see on a daily basis is chipping, discoloration and staining, marginal leakage, debonding, and secondary caries. And these, like I said, these things kept me awake. And we're not going to go into details on how we manage it and why it chips. I'm just giving you a broad overview of the cases I do and why I enjoy composite dentistry. There you can see there's about 4 studies being done on the complications and failures of resin composite direct and indirect veneers. And in over about 5 years, you can see that it's about an 80% success rate. And it's not the best, but it's also not that bad. So I always tell my patients, let's look for the next 5 years and we're going to get 80%. And then when you get to the complications and failures, most of the failures is just a thing that you can fix and patch along the line. You don't get complete failures where you need to redo the thing, like in a veneer. If a veneer chips, you have to redo the thing. We can manage all the complications and failures chairside and very cheap. And then in 2019, after doing these cases for about 4 or 5 years, I always worried about it, and I was always wondering, am I on the right track? Am I doing the right thing? And in 2019, I met these 2 gentlemen. The one on the left is Pepe, Giuseppe Sciodera. He's from Italy, and he's a member of and a publisher in the Style Italiano group. And for the guys who's following Style Italiano, it's an amazing resource for especially composite work as well. And there's definitely a big push in the composite way, and all these cases that these guys show is just amazing. So I would definitely recommend you guys get on there. There's Mark Bowes that spoke the other night. He published in there. It's amazing dentistry being showcased for free on the Style Italiano website. But what I learned from Pepe Me and John van Lierop spent a weekend with him up in Joburg when he was down here talking for 3M. And what I learned from him was the first thing is essential lines. When doing posterior composite work, we sometimes get bogged down and try and do it too fancy and try and put in all these fissure stains and fancy things. But he came out with essential lines, and that's basically what it is. It's the name is the essential lines that you want to put into your posterior composite anatomy to give you an acceptable result. And the other one is essential shape. And essential shape is the primary and secondary and tertiary shapes that you would put onto your anterior composite veneers. And it's a little card that you get, I think, when you do the course through Mark, the Style Italiano course, Mark and John, you'll get a card like this. And it's really a nice little tool to help you do proper posterior composite dentistry. The other thing, and the more important thing that I learned from Pepe, is deep margin elevation. He explained it to us. Now, the reasons our composite and our dentistry fails, especially in the posterior, is because we don't isolate properly. We don't use rubber dam and we don't isolate, and then our bonding fails on the teeth, and then we get secondary caries, and that's why restorations fail. Most restorations fail not because of the material choice, but because we didn't clean them properly, we didn't use maybe magnification, or we didn't clean the cavity properly, and we didn't isolate. And isolating these deep margins has always been very tricky. You can't get your rubber dam down there. The rubber dam keeps on flipping up, and when you sub gingerly, bonding goes out the window. So deep margin elevation was also described by Pascal Magne in 2012 in the American Journal of Aesthetic Dentistry, and he spoke about deep margin elevation, a paradigm shift. And these are the kind of tricks that I learned from him, is to bring everything up to above the gingiva. There you can bond properly, there you can see properly, and then use your rubber dam to isolate. This is also a technique that's minimally invasive, because some of us would go down there and do a crown lengthening. So it's a very minimally invasive technique just to get all your works supragingival. The other guy I learned a lot from is Monarch Versant. Now, Monarch is a dentist in the UK. He works in the Fresh Dental Institute. And what they do is he teaches a lot of composite courses around the world. Me and my friend Altus went to a course in Dubai. And what I learned from Monarch is the power of free-handed composite veneers. And like I discussed previously, we're in an era where cost is unfortunately always an issue, and we always have to look at cost. And doing something free-handed means we don't have a label for wax up. We don't have to spend time on that. We use our own hands, and we use some composite out of a tube, and we can build something amazing. And the amount of lives that I've seen changed by just doing a very simple technique like a composite, free-handed composite veneer is amazing. And the cool thing about this is a skill that you learn. You can go home with a bit of wax and a bottle of wine. You can start playing with wax and building up teeth, and train yourself to do proper composite veneers, because at the end of the day, you're going to have that patient walking in that doesn't have money, doesn't have time, and you've got him there for 2 hours, and you can actually change his life by doing proper composite veneers free-handed. I also mentioned that why I like it is because I know I can isolate when I do these cases. I can put a rubber dam or split dam on, and I can isolate using my matrix band. Style Italiano also came out with those veneer bands that they brought out. I can't remember the name now, but it's an amazing little tool that's coming out, or tools that's coming out to do these kind of free-handed composite work. And I can really encourage you guys to get involved with that, start playing around with that, and start being bold, and start building beautiful smiles with using composite only. The other thing Monarch taught me was to have deep pockets and short arms. Now, that's the thing that stuck with me all the time since I met him. And he said to me, yeah, but all I've got is surgery and a reception, and I've got nothing else. I've got no technology. And even Pepe from Italy, both these guys are amazing clinicians. They do world-class work, but all they do is use the basic tools of the trade. Now, that surgery you're seeing on that slide is not my surgery. It's my partner Jan's surgery. And what I really like about the layout he's got is we spend about 10 hours in our surgery a day, or I do. That's about a third of your life that you spend in one room. So if you're going to spend so much time in one room, you've got to make sure the room is big enough for you to at least get up and walk around and do something. So what I'm trying to get to is a lot of us are spending money on equipment and spending money on fancy CBCT scanners and Cerix and the wand and milling things, but we're not making it comfortable for ourselves. You need to have a room where you can sit back, you can enjoy your day. You need to have a TV like you see there, where you can show your cases to the patient, where you can discuss treatment plan. And that's all you need. You don't need to have all these fancy equipment. Mark Bowes also mentioned it, and I think I want to add on to what he said is, I'm not saying not owning the equipment. You can still use the equipment by not owning it. If you are an implant dentist and you place 5 implants a day, then by all means go out there and buy yourself a CBCT scanner, because you need that. But if you place an implant every 6 weeks, you're better off sending the guy down the road, get a scan taken there, and then place your implant. Or if you want to do minimally invasive overlays using getting it milled, you can still just take an impression, send the impression to your lab, and they can mill it. The labs are amazing. They've got all the technology, they've got all the milling units, everything you need. They've got all the software to do proper wax ups. If you want to do smile design, you don't have to go and spend so much money. You can use your iPhone, you can use your iPad, buy one case and do a smile design per case. So having deep pockets and short arms in a time like this, I think is very important. We've been lying awake stressing about overheads and where our money is going, and we don't have to have all the bells and whistles. We need to have a comfortable room we work in. We need to have fun while we're working there, but we don't have to have all the things. The other things I just want to go through that I think is very important when doing bonded dentistry is rubber dam is super important. If we're not placing rubber dam, we're really not, we're doing our patients a disservice. And I think that's one of the things that's been around forever, and we've always spoken about it, but we don't take the time to place a rubber dam. And once again, in the coronavirus era we're living in, rubber dam is a no-brainer, and it must be placed at every single procedure we do. The other thing that's changed my life personally was using magnification and illumination. I always used to think it's just for older guys that can't see properly, but as soon as I got proper loops and I could see what I'm doing, my dentistry definitely went up a level. And not just using magnification, but you've got to have a light and you've got to see what you're doing. And I'm not saying you have to go out there and buy the most expensive microscope, because that's not really necessary. But getting a good set of loops and spending money on a set of loops is money very well spent, and your patients will definitely get the benefit from that. Instruments is another thing. If you're going to do composite dentistry, you need to invest in good instruments. This is a set from the Monarch Fasant range. He's got his own composite range from Depler. I bought that in Dubai, and they're amazing instruments. But locally, they've got the Style Italiano, it's got the LM Arte range that's available from Iverdent. So those are also amazing instruments. And if you want to do composite dentistry and spend time creating nice restorations, you're gonna have to spend some money on proper instruments. Photography, it's another no-brainer. We spoke about social media, and I'm going to speak about it again, but if we're in social media, we want to show our work, we need to take proper photos. So go and spend some money on photos, on photography equipment. We also use that to communicate with the labs. We use it to evaluate our own work. So photos it's really worthwhile maybe doing a photography course and spending money on your photo equipment. And then the last one, social media. I've spoken about it quite a bit, but it's really all the attention at the moment is really on this device. All the eyes and ears are on these things. So if we're not there, people are not going to see us, and people are not going to come to you. They're going to go to the guy next door who's actually advertising his work and showing what's out there. So last thing I want to talk about is the 5 elements of the less is more approach, but to go a little bit beyond dentistry. Now, the first one is to maintain most of your sanity. We're in a very stressful job. We're in a very stressful era at the moment. And I think it's very important to have small victories in your week and in your month, maybe, and something to look forward to. I think it's very important to always have something to look forward to. So if it's maybe that coffee date you've got with your wife in your lunch break, or maybe a surf with your kid after work, or maybe the weekend that you go to the bush with your friends to go hunting. But it's important to have something to look forward to keep your sanity. This other one is minimize the amount of negativity involved. I firmly believe that we become the average of the 5 people we spend the most time with. So if you're going to spend time with negative people, they're going to draw you down to be as negative as they are. And if you're going to spend time with positive people, they're going to bring you up to their level. So if you in dentistry and you're negative and you're not enjoying what you do, maybe you should look at who you're spending time with. Are you spending time with optimistic people who's enjoying dentistry, or are you spending time with negative people? The other one is utilize the 8th wonder of the world. Now, the 8th wonder of the world, Albert Einstein said, compound interest is the 8th wonder of the world. And those who knows this gets the rewards and or gets the money, and those who don't pays it. And the 8th wonder of the world only means that invest and start saving early. Start putting money away at a very early age. Don't wait for when you get older to start saving. Invest early, and the 8th compound interest will help you earn a lot of money in the long run. And that ties in with delayed gratification. The author Brian Tracy says that the ability to discipline yourself to delay gratification in the short term in order to enjoy greater rewards in the long term is the indispensable prerequisite for success. So if you want to buy that new boat or the new set of golf clubs, or I don't know, you guys buy up in Pretoria, but maybe delay the gratification, and long term you'll reap more benefits. And then the last thing I want to get is enjoy the phase that you're in. All of us are in different phases in our lives and doing different things. My partner, for instance, Jan, he's in a phase where all his kids are out of the house, and he now owns 6 motorbikes. He takes off every Wednesday and he surfs pretty much every day. But I'm in a different phase of my life. I can't jump on 6 motorbikes. I've got a 4-year-old boy, and I'm busy teaching him how to ride a bike, and I'm teaching him how to surf. So you've got to recognize where you are, and you've got to enjoy that period of your life. And in dentistry as well, we all can't be Dr. Mark Bowes and show these amazing cases. Some of us are sitting in the sticks in the Eastern Cape, and we've got to make use of what we've got. And I want to add on to Mark. I just want to give a shout out to Mark. Basically, he's an amazing educator, and we're so fortunate to have him between us. And I always look up to him and the work he does. And he mentioned the make it count, and making it count for him was showing these amazing cases and showing these amazing rehab cases he does. But making it count might be completely different for you. Wherever you are, you can still make it count. Maybe you are Sally Smiles from Secunda, and you do an amazing tooth whitening, and you post it on Instagram, and you write a short post on how smoking discolors your teeth. Maybe 50 people sees it, 10 people consider quitting smoking, and 2 actually does quit, and they come to you to get the teeth whitened. And that's also making it count. Or maybe root canal Rick from Roodepoort uses rubber dam and magnification. He spends 15 minutes extra finding the mesiobuccal 2 canal and posts it on Facebook. Not only is he saving Ron from getting an implant 5 years down the line, but he's also motivating Dr. Resin Ruby to use rubber dam on all the bonding cases. And doing that also makes it count. And then minimally invasive Martin from Menlyn does clear liners and composite bonding after 9 months. Saves 25-year-old Marty from getting a teeth file down for veneers. He makes a short video about this and puts it on YouTube, and 500 people watches it. 20 people considers this approach versus the veneers, and 2 end up coming to him for treatment. And that's also making it count. So I want to just motivate you guys that the little things we do is massive in the long run. the little things we do is worth doing properly, and it's worth making it count, and it's worth putting it online and showing the world out there that what are you passionate about and what are you doing. And it's important to document your journey, and not just creating things. So document where you are, show us how you make those anterior composites, or how you place that rubber dam, and the small thing, and it really make it count. All right, so that's it for me. We're going to go to the competition, and then we're going to go to questions and answers. So the competition is, you're going to come down to the Eastern Cape to one of our composite courses. You're going to spend time with my wife, Carmen, eat the food she makes. You're going to do the course. You might be standing next to Alvin on the boat. That could be you standing right next to him. And you're going to enjoy some beer with Altus and enjoy his funny jokes. And the competition is, all you need to do is you need to follow me on Instagram at Dr. Evert Burger. And then you need to slide into my DMs, and you need to tell me how many years has Julie been married to her husband. If you want to go back and count the rings on her husband's teeth. What do you call someone that stalks you on Instagram? And what's the 8th wonder of the world? All right, so if there's any questions, I'm happy to answer some questions. If you ask a difficult question, you're not going to go on the boat with Alwyn. All right.
Thank you very much, Dr. Burger.
Okay.
Less is indeed more. And it's important to do that while you're making it count, as Dr. Bowers has already taught us. So we're going to go to our questions panel, and I'm going to cover the first part of the questions, and then Dr. Erasmus will come through. The first question is regarding the first patient that you presented on. What technique did you say you used to open the bite? Please elaborate.
I didn't open the bite at all, so I used the dial technique where I opened only the anterior teeth, and I let the posterior teeth erupt into place. So the dial technique, it's called.
Okay. And then we've got Dr. Bagwan, who wants to know, what do you charge for composite veneers?
I think it's a good question. I think it's something that we should consider.
Dr. Burger?
Can you hear me? Yeah, it's a good question, and it's
now
something we should consider. And I always tell people that ask me that is, you must figure out how much value you're adding to the patient. So it's a very difficult question. Sometimes I charge less, and sometimes I charge more. But it's important to charge enough, because you do spend a lot of time, and there's a big risk for complications. So when I asked the same question to Monik Fasant from England, he said to me, how long is a composite veneer going to last you versus a porcelain veneer? And I was saying probably half the amount of time. And he said, well, then you should charge half the amount of what you would charge for porcelain. So you can use that as a guideline, I think. But charging too little, you're going to rush it. So you should charge a fair amount. But I always say, if you're going to add a lot of value, and you're going to then charge more. But if you're doing a couple of lowers, maybe charge a little bit less. So half of what you would charge for porcelain restoration, I think is a little bit much. I'll probably charge a little bit less than that. So I don't know if that answers your question.
Okay, I hope the participant is happy with that response. We've got Dr. Bartley, who also wants to know, to do freehand composite is not an easy task. How do you manage to get such good results without any preformed templates or guide?
I think it's important to know it's a journey. It's not just an end point. You've got to start doing these things. The 20 cases I've done that doesn't look as good, I'm not going to show you guys, because they're lying there somewhere, and I deleted the photos more than likely. So it's the process that you go through, and it's a thing that you start playing around with, and you teach your eye. Like I said, it's sometimes good to just take some wax and a model and just start doing wax ups at home and using your composite instruments to get a feel for it. But obviously, if you can get a wax up done, get a wax up done. But I enjoy doing it freehandly. It's like a little passion for me, and I like playing around with it. And I like reading up about it. But understanding morphology, understanding shape, understanding that it's not all about color, but it's about how the light reflects from the tooth. And I think if you start doing these things and start carving teeth into wax, you understand the principles. And maybe I've got some books that I use as atlases. So it's just getting into it and getting stuck in and doing it. But remember, the average guy out there doesn't really care about what it looks like. He just wants to have a straight white tooth. So if you're sitting somewhere in Polokwane and a guy comes in and you want to do 6 teeth, play around with it. I mean, you don't charge him that much maybe, but a lot of these cases, the people just want to get the black marks out. And so you do a composite veneer case, it's not going to look great. You might not post it anywhere, but start doing these cases. The patients really love it. They love the result. And explain to them the pros and cons of it. But I think it's a thing that it's always evolving, always changing, and you should always be playing and training and getting there. But getting wax ups done is not a bad idea earlier on, so you can have some reference to work from. The other thing I just want to mention is I got some models from Germany. I think it was, I don't have the name with me now, I'll find out, but it's basically the DSD models but printed, and you can look at them as a reference point and you can play with them, and you can yeah. So spending time playing and training your mind and training your eyes is a good thing.
Absolutely. Thank you so much, Dr. Berger. Dr. Chetty would like to know, do you use a single shade technique or separate enamel dentine shades for anteriors?
That's also a great question, because I just touched on it a little bit. Now, we always think that we have to go and do shading and do all these amazing layering techniques. And I think, in my opinion, we're doing a cost-effective treatment. So to do a layering technique, you might as well, it's going to be so difficult and technique sensitive that you might just take an impression and get a crown done. So I like to use a single shade. It's quicker to fix, it's quicker to add on to. And like I mentioned, it's more about the shape of the tooth and not so much the layering of the tooth. If you're doing these big cases, if I'm talking about a single tooth and I have to match a tooth next to it, then I would consider doing layering and doing effects and doing tints and all those things. But if you do a rear kind of case, a composite, a full 6, 3-3 or 4-4, then I would always go single shade. And I'd always remember that the way the light reflects from the tooth is more important than the layers you've got.
Okay. Thank you, Doc. What material are you using for deep margin elevation on the deepest level of the restoration?
That's difficult. You can use a glass ionomer, but if I tend to like using a composite, so a flowable composite. If I can get a good marginal seal and I can look down there and I can get my matrix band tightly adapted, I'd always go for composite. If I'm in doubt at all, then I'll try and use maybe a glass ionomer type of material, but I always try and make sure that I can get a good seal, and then I would use a flowable composite and lift it up to the
Thank you, Dr. Berger. There is one question that is in the chat, so I'm going to cover that and then hand over to Dr. Erasmus. Okay, Dr. Erasmus, you can continue from here while I try and locate the question. It's from Dr. Bauer's comment.
Okay, let me just get to that. His comment was great presentation. The main reason why injection does not work is wax is not accurate. They need to be designed digitally. Don't know if it's a comment or question.
I think our lab does everything digitally. And I think the design is nothing wrong with the design. My concern is the adaptation to the margin. I'm never sure if I'm getting marginal leakage and marginal discoloration in the long term. So it's just a personal thing of mine. That's why I always tend to enjoy going for a matrix band, and I can see that I'm isolating properly. It might not be a problem. I've never seen it being a problem. It's just a suspicion of mine. And like I mentioned, I enjoy doing things freehand, and I like doing being a little bit creative with it, and I don't need a wax up for it, but a wax up and an impression, the injection molding technique, I think is an amazing technique where you get amazing results, where you don't have to think about it. You can copy nature, and you can do it digitally. So I think it's really a great technique to use.
Thank you. Next question. When doing deep margin elevation, how do you maintain a dry field for bonding?
Well, that's important to isolate properly and to use your matrix band properly. So in the article that a paradigm shift from Pascal Magne, he explains a couple of steps, and one of them is to cut your matrix band and place it as deep as possible. One of the issues when doing these things is if you try and put a wedge in there, you kind of fold it over and you get like a little wobble on the inside. So it's just important to get a matrix band down there and isolate properly. And there's a lot of techniques in doing that. Also, if you can get a wedge in to isolate, then you're going to use a wedge. It's obviously got its limitations. There's some points where you'll never get in there and you'll have to do a crown lengthening and maybe gingivectomy with a laser. But I think spending time, I think it's important to separate the deep margin elevation from your restoration, and to spend time on getting that margin elevated, and also to charge for that, not just to think I'm doing a big filling, but to think now I'm doing the deep margin elevation and I'm spending time on isolating this and I'm just building it up to go supragingival. And then the next step you do is do your restoration.
Thank you. Question often asked is, how do you finish off and polish these composite laid veneers, getting them smooth and shiny?
Yeah, so there's a lot of techniques, obviously, and there's a lot of polishes on the market, and I think they all work fairly well. I think the important thing is before you polish is that your final layer should be one layer that's not being patched up. You should use the final layer should be a single layer that you place, and you can we teach the technique is when you place it and you spread it, and there's no bubbles and there's no dents and there's no indentations, and then you polish with any of the polishes available. I enjoy the Eve polishes, that pink Eve polishes, and I normally just use the two of them. Another thing I use when I finish that a lot of people don't use is a scalpel, a number 12 scalpel blade. Sometimes you get a little overhang interproximal, and you can kind of shave the composite pretty nicely with a scalpel. So my advice would be to make sure your final layer is a single layer that's not been patched up. And then when polishing, all the polishing things out there, the Eve polishes in my hand work pretty well. They've got the little pink one and the little white one. I only use them. And then you've got these polishing pastes and stuff that I don't really use. I also don't really use any coatings that you cure, light cure afterwards, because those things just come off anyway. So yeah, any polishing system, the Eve polishes work amazing.
Dr. Matseng, you want to come back to your question first?
That's fine, Dr. Erasmus. Please explain the essential lines concept on your slides.
Okay, I'm going to go back to them quickly. Just give me 1 second to go back to them. Right, so the essential lines on the left-hand side, you can see that black card, and that's a card you physically get. And I'm sure on the course that Mark presents for Style Italiano, they give that card. And when looking at and on this card, you can actually, on the hands-on, you play around. So you put your composite on there, and the picture I'm showing here is that's the lower four. I mean the lower 4, 5, 6, and 7. So these lines that that Pepe made is the essential lines that you place. So the first thing you do is, when you look at the bottom picture, is after when you've got your restoration and you're ready to start placing your morphology, you find the middle point, the center point of the tooth. And you can see in this slide there, there's a center point. So that's the first thing you do. The second thing is you find the highest spots, and you'll see in these little pink dots there, those are the highest spots of, the lowest spots in the tooth. And then all you do, and all the essential lines then does, is they join those spots together. So from your cusps going down into your fissures, you join them, and you get the essential lines. And you can see on these on the cards there, for the lowers, those are basically the lines that you'll follow, and the uppers, those are the lines that you will follow. Does that answer the question?
I hope so, Dr. Berger. I think if it doesn't, then the participant will send a follow-up question.
Okay.
We've got the next comment here from an anonymous attendee. It's a pity because they're giving you a compliment, Dr. Berger, so you can't even slide into their DMs to thank them. They're saying that excellent presentation. So we've got Dr. Summers next. When is the next composite course in Jeffreys Bay?
I think once the lockdown is over and the summer is here, so probably October, maybe early November. So we'll obviously see what the lockdown allows us to do, but hopefully early spring and early summer.
Okay.
We want to spend time on the river, so it needs to be warm.
Lucky you guys, unlike us on the dry side of the country. So yeah. But anyway, Dr. Summers has a follow-up question. He'd like you to explain more your photo taking techniques or protocol, as well as the equipments that you use. Also your final polishing and anatomy protocol, as well as what composite you are using. I think you covered the composite that you're using, the photo taking protocols, and the polishing and anatomy protocols.
Okay. All right. I think when taking photos, it's very important to always take more photos than what you think you need. A lot of times we do cases, and I actually was in this week, someone asked me for a case, and then I looked for the photos and I couldn't find the after photos and I couldn't find the before photos. So it's important to take photos of pretty much all your cases. If you see a person coming in, I always take a profile photo, and they never want to share those photos. Then I take a smile, extraoral smile photo, and then I put retractors in and I take intraoral photos with my mirror. So the equipment I use is just a normal Canon DSLR camera with a macro lens, a 100mm Canon macro lens, and a ring flash. I don't think I've also got the flash with the twin flashes, and with another camera, but I'm struggling with that setup. It works very easy for me. The ring flash is not ideal for aesthetic dentistry. I think twin flashes work better, but we tend to overthink everything, and we want to invest in all this stuff. And once again, less is more. But spend money on a camera, spend money on a macro lens, and spend money on a ring flash. And all of these things you can find secondhand. Get a good mirror and get good retractors, and take a lot of photos. So the settings you can obviously look into. There's a lot of information out there on what settings to use and where to use them. So there's a good article on Shoot Like a Pro. If you go on YouTube, there's a video, Shoot Like a Pro. That's a lecture that was given at IDS, and it's all the basics you need for dental photography. So you can look into that. The other question was the morphology. Is that right? Okay. So
the anatomy and finishing.
Okay. So the way I do it is, it's another thing we tend to overthink, and when doing the anatomy and the finishing, it's always at the end of the procedure. Everyone's tired and everyone wants to get out of there. So a lot of times what I do is I finish the case, I polish it, and I polish it to a reasonable polish. And then I say to the patient, okay, go home for a week and get used to your new teeth. A lot of times in that week, the things that was bothering you with the case now doesn't bother you anymore. And the things that's bothering the patient, they can tell you. And then a week later, I set aside an hour or so. And then what I physically do is I take a pencil and I start drawing in the anatomy. I then take a fast handpiece with a red ring, and I start cutting in that anatomy that I want. And then I start polishing it. And then after polishing, I would then sit up the patient again, and I would look at all the lines. I look at the line angles. I make sure all my line angles are in. I make sure it fits the patient's mouth. It's very important to not just sit behind the patient and do the work. You need to get the patient up. You need to make sure the midlines are right. You need to make sure all your lines are looking straight, and you've got all the basic anatomy and morphology in. And then I start using my my pink Eve polisher, and I polish all the teeth up. While polishing, a lot of times if you've got pits or fissures, you'll see them showing up as a little stain. So I don't use water when I polish. I use a slow speed, and I polish without water, and you'll see the pits showing up as like a white powder mark. Then I'll take my fast handpiece and I'll try and cut that out. If it's a bubble or anything and you can't get it out, then I would just make a big cut, and I'd use a flowable composite, and I'd build it up again, then I'll polish it down. So it's important to go through those steps. Firstly, cut your anatomy, get the basic anatomy right, send the patient home, then come back and get the secondary anatomy, draw it in with a pencil, get your line angles in, get your all your incisor lines right. And then the thirdly is get the tertiary anatomy in. If you want to be fancy, you can play around with everything, but I think it's important to pause between doing the work and doing the final polish, and that week in between is a nice time for the patient to reflect on what you've done for them, and also for you to reflect on what you did, and then you do the secondary and tertiary anatomy and you polish up. Does that answer the question? Just to talk about the composites I use, there's a lot of composites out there now. I think they're all amazing. 3M, the new Filtech Universal, I think is an amazing composite, and I've used that for about a year, and I've got some amazing results. And all the Ivoclar composites are really nice. I've been using them for a long time now. So I think you need to spend money on a composite. Don't use the cheapest composite out there, but they all work, and they all have different ways of placing them and different techniques. So get used to the composite you use and spend time with it. Don't give up after one or two cases. Sometimes their properties are just a little bit different than what you're used to. So spend a little bit of time before you give up on a composite.
Thank you, Dr. Burger. Dr. Spinola, deep margin elevation, what material would you use for the proximal box?
For the like I mentioned earlier, I would use a flowable composite if I can get proper isolation.
Okay. Dr. Pretorius, which course do you recommend to improve composite techniques?
Well, I think in South Africa at the moment, there's two courses. There's Mark Bowes and John van Leerop's course, Style Italiano course, and then we've got our course that we present in the Eastern Cape. And then when looking abroad, there's a couple of online courses. I can't remember the guy's name now, but I'll look it up for you. There's a guy that just brought out an online course from Brazil. That's quite nice. And then the course I went and did from Monarch Fasant in Dubai was really an eye-opener and a nice course to do. So I would definitely recommend my course, but Mark Bowes is obviously the legend in Cape Town, so his course is going to be a lot of good value for money.
Dr. Burger, you've got a compliment that has a name and a surname, so you can slide into their DMs. And Dr. Faranas Parker says, well done on an excellent presentation. I especially enjoyed the holistic approach, integrating your expertise with a positive outlook on life. Very important in these times. And she's actually your classmate.
Okay. Thanks a lot for the nice compliment. I really appreciate it.
Like that. Do you pre-treat your cases with ALF appliances to improve the alignment and then ultimately reduce the thickness of your composite buildups?
Yeah, I think the ALF appliance is an amazing appliance that we should be, and personally should be using more. I've done a few of these cases, and it's really an amazing minimally invasive approach. And the problem with me is I tend to think in composite and not in orthodontics, and I think it's a big issue. I always think pre-treating with orthodontics, any appliance, whether it's clear aligners or ALFs or whatever you want to use, is a great idea, and you should always consider that. So first of all, always do pre-treatment, get the alignment right, and that's where stuff like smile design comes in, to make sure you prep no teeth, no matter what you're going to put on them. If you don't want to prep teeth, so getting the teeth moved into the right positions is the gold standard in my opinion, and then it would be ideal to use as little composite as possible. Yes.
Okay. Another question from Anonymous. How do you choose your shade, and what's your most common shade?
I think my most common shade is probably A1. I tend to not go too white. So I don't like the bleach shades at all. So I stay away from that. And once again, we've got an older community where we work. So A1 is like the bleach shades for the rest of the country, I would think. So A1 is definitely my most popular shade, and A2, I suppose, as well. And how I select my shades, it's obviously important to distinguish, am I doing a single tooth restoration or a big case? And when doing single teeth, it's important to take your time with the shade matching and stuff. Just to get back to photography, to use, I'll get to it now, but obviously good sunlight, getting up, not using overhead lights when using your shade selection, standing in an open air where you can see and using your shade guides. But when I do a big composite case and I'm going to change everything, I always show the patient the shade guide and say, where do you want to go? But selecting shades and doing the big cases is very easy. You just go 1 or 2 shades lighter, I think. So it's not a big issue. It's difficult when you get to the single teeth. That's where shade taking is quite difficult. And putting a blob of composite on the tooth and cure the tooth and let the patient walk around 5 minutes. It's so easy to do, and it gives you it helps a lot.
Okay. Thank you, Doc. And then we've got, I think Dr. Osman and Dr. Bowles are responding, but then we've got Dina who says, don't you think that composite veneers are not strong enough for a patient who grinds his teeth while sleeping?
I think not even teeth is strong enough for a patient who grinds his teeth while sleeping. So she's 100% right, yeah. And once again, it goes back to function. We need to treat the function first before we put the things on. So 100% correct. A patient that grinds the teeth, we must restore the function. If we've got the right function, it will work. It will wear and it will chip. But like I said earlier, I'd rather let my composite chip than let the underlying structure chip. Or if you've got one of these grinding patients and you load them with big, strong material, eventually something's going to give. It might not happen in the first 5 years, but sooner along the line, maybe the underlying tooth structure will break. So composite veneers will definitely break on a grinder, and that's why it's important. All the cases I do, we give them a device to sleep with. We give them a Michigan splint or something, and it's important that they use it and they sleep with it.
Okay. Marie Creek is thanking you for an outstanding lecture, Dr. Berger. And then Dr. John Nolan, do you recommend occlusal guards post-rehab?
Yes, like I just said, I always give an occlusal guard post-rehab, and I think it's very important. All of these cases, and we're seeing so many of these wear cases, and it's not just wear we need to look at. We need to look at breathing as well. And I think breathing is the one thing that's been overlooked by dentists for so long, and it's going to be, I think it's going to be focused on a lot more in the future. But we need to look at breathing. We need to make sure our patients are breathing properly. If they're breathing properly, they'll probably grind less. But we see so many of these grinding cases, and I always give some kind of appliance, yes.
Another compliment for a great presentation, Dr. Berger, from an anonymous attendee. But then they still have a question. What is the name of the dental laboratory that you use?
I use Algoa Dental Laboratory in Port Elizabeth. Ernst Linder is a technician, and he's a good friend of mine. So if you ever need a really great lab and a forward-thinking lab and a lab that's got all the bells and whistles and all the equipment, Ernst and PE is a guy to call.
Dr. Kotze would like you to explain anterior teeth essential lines. I think you explained the posterior. They'd like you to explain the anterior teeth essential lines.
Okay, so what he's got there is essential shape basically, and you've got three kind of basic shapes. You've got the primary, secondary, and tertiary. So the first thing, I don't really use the essential shape that much, but what you've got is when you do, you've got to decide which kind of tooth do you want to make. Do you want to make a wide tooth? Do you want to make a narrow tooth? Do you want to make a square tooth? Do you want to make a round tooth? So that's the first part, is getting the basic right. I always explain it to people. If you look at someone in a dark room, maybe you're in a bar somewhere, and someone sees you, you only see the shape and the outline of the teeth, like the silhouette of the teeth. So that's like the basic thing. Then the second thing you'll start looking at is the secondary anatomy, and there you'll start placing the line angles, and you'll start placing those kind of things. And then thirdly, you look at the tertiary, and that's the surface texture and those kind of things. So it's basically, you've got to look at the line angles after you've got the shape right. You've got to see how flat or how round you want to make the tooth. If you have a tooth and you've got a big space you want to close, then you don't want to make a flat tooth. You want to build up that tooth slightly, make it slightly more pointy, so that when the light reflects from it, it looks like a narrow tooth. And if you've got a narrow space and you want to make it look wider, then you flatten it down, you're closing the line angle. So tooth morphology is quite a difficult thing, and a thing that I didn't really understand until Ernst, the lab technician, came to me and said, listen, your morphology looks horrible. You need to start looking at this and that. So morphology is, I think, something we need to play around with. It's three-dimensional. It's very difficult to explain it or look at it on a two-dimensional plane. And that's why it's important to maybe take a piece of wax or take something and carve teeth out of it, so you can see how the way light falls on it.
Thank you, Dr. Burger. I think then the next couple of comments that we have here in social media language, they are shout outs. So they are complimenting you for the presentation, Dr. Burger. And then we have one that asks, which loops would you advise?
I think I had this conversation with a girl working with us the other day, and I think for me personally, loops is very important, and I would spend money on loops. But if you don't have the money, just buy any loops you can get your hands on. You can buy loops on eBay for next to nothing. But I've got Zeiss loops. What I love about the Zeiss loops, obviously, it's amazing. The lenses they use is amazing. The issue with the Zeiss loops, in my opinion, is the light they give you is horrible. So guys like Zoomax, I think it's David Dubell, or Peter, David, I'm not sure. They give amazing service. The loops work. It's a fair price. So I would support those guys. I would always think about maybe getting a little bit stronger. I've got a 4.5 magnification loops. You can start off with a 2.5. I think you grow out of a 2.5 pretty quickly. So it's a difficult thing, because if you buy a set of Zeiss loops, it's quite expensive. So if you're starting out on loops, get something 2.5 or 3.5, but you want to work your way up to maybe a 4.5 or 5 times magnification.
Okay. Dr. Conradi actually says that this is one of the best webinars that he's watched, and he's thanking you.
Great, thanks.
Anonymous again would like you, can you recommend a packable composite that is ideal for posterior restorations?
I don't think I can recommend any composite, because I honestly think they all work. What I like about the Tetric Enceram is it's really radio opaque. So when you place it, it really looks nice on the X-ray. But the Universal from 3M is an amazing composite, and then the 3M has now got the posterior Filtech 1, I think it's called, and I've been using that for a little while. It's also an amazing composite. So you need to decide, firstly, what kind of material do you want to use, a bulk fill, or do you want to use a packable and layering? But all the composites work. I tend to stay away from bulk fills. I kind of layer my composites still a little bit, but the bulk fill ones surely do work. And the new one from 3M, the Fulltech one, really works amazing. So all of the big name brands I can definitely recommend. They all work. They're all in my hands. They all work. I like the fact that the tetric NCERAM is so radio opaque, because it really looks nice in X-rays.
Okay. I think we're going to cover the last question in the interest of time. We're just going to do the last question, and then the rest of the questions that we haven't covered, Dr. Burger, as I had indicated, we will send them through to you. And then I'm going to hand over to Dr. Erasmus just to give us the vote of thanks, and then I'm going to close off with the notices that we have. The last question: how does bonding work if you are not prepping the tooth? What bond do you use?
Just say again, what bond do I use?
Yes. And they want to know, how does it work if you're not prepping the tooth?
Okay, so I'm assuming you're asking, we're doing, let's say, an anterior veneer. We don't have to prep anything. So prepping, we're not cutting the tooth at all, but we need to still condition the tooth. So the conditioning is all the normal bonding protocols apply. First, the most important thing that I would use is a sandblaster to clean the teeth off properly. You want to clean off the biofilm. You want to make sure there's no biofilm. If you don't have a sandblaster, you can use a fast handpiece with a very a diamond burr with a very light cutting, and just clean off the tooth. Basically, don't cut the tooth, you just clean it off. But sandblasting is the gold standard. Then obviously you etch like your normal bonding protocol. The first thing you do is you isolate properly, then you etch the tooth, and then you apply your bonding agent, whatever bonding agent you're using. I like the universal from 3M, and you paint it and I scrub it on for 20 seconds. I then leave it to let it seep in, and then I blow dry it. I heard an article and I read an article, and the guy said you shouldn't be blow drying because that introduces water. So whenever you blow drying your bonding agent, make sure that there's no water in the line. So just give it a couple of squirts on your leg and make sure that the line is clean. You can also, if you really worry, you can install a separate line that's only compressed air, and you'll always know there will be no moisture contamination. But Monik Versand actually taught you not to blow dry it because he says that introduces air. So he says you must just rub it on, scrub it 20 seconds, and then suck it, and then suction the excess, and then light cure. So you then light cure obviously for 20 seconds. What a lot of people don't do is they don't have proper curing lights. And I think we all talk about bonding, and we talk about isolation and bonding techniques, but not a lot of emphasis is on the curing light. And I think that's a thing we should look into, is make sure your curing light is doing its job properly. If you haven't checked it, get a rep out to check your curing strength, use a proper curing light, and then place your restoration.
Thank you very much, Dr. Burger. Dr. Erasmus, okay, before I come to you, Dr. Burger, I'm just going to give you an opportunity just to give us your parting shot, and then we hand over to Dr. Erasmus just to give the vote of thanks.
Well, thanks so much, Doctor, for the opportunity to present to you guys. I hope I could teach you guys something, and I think the only thing important for me to bring over to you is that we're all sitting in normal practices, we're doing normal dentistry, and it's worthwhile lifting up and making it count for our patients and doing the basics things right. And we don't have to have a fancy practice, we don't have to have a fancy equipment, we don't have to have fancy lights going on and off, but we need to do the basics right, and we need to make that count.
Thank you very much, Dr. Burger. Dr. Erasmus.
Thank you, Dr. Mtseng. Yes, Dr. Burger, thank you really very much. I can assure you that your lecture was very relevant, I think, to all of us tonight, because I've been around a long time in SADA, and lately we're getting the questions and the comments more and more that what you're talking about, normal people with normal dentistry. I think it's tough times, and I think that's why we picked your lecture, because your ideas are enlightening, like your one friend said here as well. Your holistic approach and ideas for I think the middle class or average dentist out of these techniques are really excellent. It was an excellent lecture. And I think taking this home with us, it gives you hope that you can achieve so much more and better results with less. And like one member made the remark, it seems to him that we're always looking at the high end of the spectrum when we organize lecturers. Not that we don't consider you as a high-end lecturer. You did an excellent job tonight. We thank you for that. And I think with what you said tonight, and in combination with someone like what Mark said, Mark does his excellent lecture as well about make it count. I think those two concepts together with what you said tonight is it brings something different for the way forward and what we may need in South Africa. So we really thank you for that. I'm just concerned, I just want to ask how many lodges and bed and breakfast do you have in Jeffreys Bay for your course?
We've got more than enough. Don't worry about that. We've got a lot of accommodation. So everyone's welcome to come down here and come visit us. And I'm looking forward to seeing you guys.
Thank you. Thank you, Dr. Metsing, for you.
Thank you very much, Dr. Erasmus, and thank you, Dr. Burger. Protocol states that once the president has spoken, no one else can say. So I'm just going to stick to the announcements and then we'll close the evening. Please note that you will be eligible to 1 CEU for this webinar that you attended this evening. You will receive 1 CEU. Our next webinar will be on the 3rd of August, and it will be with Dr. Bradley Bredenkamp, and he will be presenting on oral disinfection and COVID-19. So you better start registering for the webinar. And yeah, I think thank you very much to the Pretoria branch for arranging this particular webinar. Dr. Erasmus, Dr. Burger, I think we're gonna just stick around a little bit while our participants are logging out. I think participants, you can start logging out now. It's the end of our session. Okay, we have numbers, people that are logging out. So Dr. Burger, we will forward you the questions. Marlies will send you the questions that were not responded to, and then you can just provide those responses. It's not so many questions. I think it's about 10 or 15 questions.
Okay, great. Thanks a lot.
Most of them will be compliments.
All right.